Hello students, welcome to ENT Thursdays, the third session, the third week of ENT Thursdays. Yes, so how are you? Can you hear me? Are we live? Can you hear me? Am I audible? Can you see me? Good evening to all of you. Eva, Inderpal, Prachi, Swati, Shibashish. A very warm welcome to all of you, and we will just start with a little about. Yes, what our aim of ENT Thursdays is. I'm sure you're benefiting from it. And my aim to start ENT Thursdays, why I thought of this novel idea is when we do something live, the aura is different, the connection is different. And in this lockdown where we don't get to see anybody, we don't get to meet our friends to discuss with each other, I found this would be a wonderful way where we can connect with each other and all of you can be together and feel that yes, all of you are preparing together. So I hope we are uh, yes going ahead in the right direction, and yes, it is very much important for you for your clinical orientation so that it benefits you not only in your profs but also in your PG entrance examination. So everybody, be it pre-final, intern, post-intern, will be benefited by it. And since we are doing very small topics at one time, and you have already studied those topics in great detail very beautifully in Marrow, maybe you do not have the access to Marrow, so you must have read it somewhere else. So when we are doing it in bits, you have a better revision, you retain things better, and when you have already studied and revised everything, and now when you see the questions, it is a challenge for you to see whether how much you know. So first, when we started, it was an idea that we will do it restricted to the Marrow Plan C users. But then, for the love of all of you, we decided that no, I decided that no, let it be on my YouTube channel and for everybody and absolutely free. So please make the best use for it. As I tell you again and again that even if the interns and post interns, because of the duties in this difficult time, if they're not able to view the live session, they can view it later on. But yes, nothing like attending the live session. But for the pre-final students, it is a must. So you should attend, you should make the maximum benefit of it. So let us start. Yes, so we are doing today the conditions of the larynx in children, and I'm sure I can see your zeal. I am sure you have prepared very well. Now, let us start with the first question. Okay, now whenever we'll do the question, let us see that whether just by reading the question we have the answer in our mind, or we before seeing the video clips. I have added many video clips here, so let us see whether without seeing the video clip also, just by reading the answer question, we have the answer in our mind. So the first question we have here is, the given child in the video came to the OPD, okay, with the complaint of high fever for 2 days, drooling of saliva, and noisy breathing. The child becomes very restless and breathless in lying supine, which improves on making him sit. True regarding the above disease is. So, without seeing the video clip, I want you to tell me what are the important points here, which are, what is the diagnosis that you have in your mind, and what are the things that you will consider while diagnosing this. So here we have a child who has come with high fever, okay, has come with high fever. There is drooling of saliva, and the high fever is for 2 days, so it is acute onset. There is drooling of saliva, there is noisy breathing. Okay, so drooling of saliva, what is the condition that you have in mind? Yes, What is the condition that you have in mind? What is the condition that is coming to your mind? Yes, yes. Why do you say it is acute epiglottitis? Okay, it is acute presentation. There is fever, so it has to be an infective condition. There is drooling of saliva. Yes, is there drooling of saliva, dysphagia or dinophagia in any condition of the larynx? Does the larynx have any role in swallowing? Yes, excellent. I can see all of you are giving me the right answer. Yes, because the epiglottis has to close the inlet whenever we swallow. So whenever the epiglottis is infected, swollen, then there is difficulty in swallowing. And in kids, they do not say that I'm having pain in swallowing. They are not even able to swallow the saliva, that is drooling of saliva. Noisy breathing. Noisy breathing is, yes, a stridor. But here it is not mentioned with stridor. What is a stridor in acute epiglottitis? Yes, what is the stridor in acute epiglottitis? The child becomes very restless and breathless and lying supine. Again, in which conditions of the larynx will the child have difficulty while lying supine? Yes, when there is supraglottic involvement. Yes, very good. In supraglottic involvement, as the child lies supine, the epiglottis falls down further, obstructing the larynx and improves on making him sit. Now, before we go to the choices, let us see this clip. Yes. So, could you hear it? Could you hear it? Yes. Could you hear the stridor of the child? Yes, Pragati, Divya, Venkat, Sarthak, Swati. Could you hear the stridor of the child? Could you make out what the stridor was? Whether it was in which phase of respiration, inspiration or expiration, or both? Yes, could you hear? Very good, you heard it. Okay, heard it clearly. So what stridor was that? Yes, it was inspiratory stridor. Very good. It was, yes, very good. It was a inspiratory stridor. So inspiratory stridor we know is seen whenever the obstruction is at what level? Quickly, at what level? Yes, either at the supraglottis or at the glottis. Yes. Now let us see, we have the diagnosis in our mind. It is, very good, it is a supraglottitis or acute epiglottitis. So what are the choices? Immediate pharyngeal and laryngeal examination should be done in the OPD. So always, please always mark whether you have to mark true or false. This is somewhere where you do not mark, then you can forget while reading the choices whether true was asked or false was asked. So immediate pharyngeal and laryngeal examination should be done in the OPD. What do you think? Should we do the pharyngeal and laryngeal examination immediately? Yes or no? Yes or no? B, C, E correct. Yes. Prachi says B, C, E correct. Is A correct? Immediate pharyngeal and laryngeal examination should be done in the OPD. All of you? Yes, tell me. Immediate pharyngeal and laryngeal examination. What do you think? Yes, it should. It should be done. FOL should be done. Should we do fiber optic laryngoscopy? Should we go for laryngoscopy in this condition? In, yes, so please listen to this carefully. This acute epiglottitis in children is one contraindication to examination of the pharynx as well as the larynx in children. In children, the moment you examine the pharynx, examine the larynx, the child goes into laryngospasm. The chances of the child going into laryngospasm is very high when you're examining, when you are dealing with the pharynx or larynx, when you're stimulating these areas. So immediate pharyngeal and laryngeal examination should not be done. So this should not be done. This should not be done. So we have the yes, the next is X-ray should be done. Yes, so whenever, please remember this, whenever you are in the OPD and you will see any patient, any child adult, you can go for indirect laryngoscopic examination, but not in a child. Whenever you are seeing any child where you are suspecting acute epiglottitis, don't examine the pharynx, don't examine the larynx directly, go for a X-ray. Yes, and on X-ray, yes, very good. Meet says that we see thumb sign. Yes, we see the thumb sign. Thumb sign on which view? Yes, very good. We see it on the lateral view. So this is correct. Patient should be started on ciproflox. Is that correct? Ciproflox. Should we give ciproflox to this patient? What is the organism here? Yes, I saw. Yes, somebody was writing that it is beta hemolytic strep. So is it beta hemolytic strep? Is it staph? Is it H influenza B? Yes, antibiotics, thumb sign. Yes, tell me, antibiotic should be started. Which antibiotic should be started? Should be start ciproflox. It is against, yes, the organism is beta hemolytic strep. Group A beta hemolytic strep is the most common organism nowadays. Is ciproflox active against group A beta hemolytic strep? Yes, it is X-ray. STN is soft tissue neck. STN is a soft tissue neck. Soft tissue neck. Yes, group A beta hemolytic strep. Yes, H influenza B used to be the most common before vaccination of H influenza. Nowadays, it is no more the most common cause, because of which also the chances of acute epiglottitis has gone down. So yes, it is. Yes, it is either penicillin or it is third generation cephalosporin. Ciproflox does not act. So here is where your knowledge of pharma comes into account, that you read all these drugs, which organisms it is active against. No, so ciproflox, this is incorrect. It involves the supraglottis and the glottis. Yes, along with antibiotics, humidification, very important, steroids, very important, adrenaline nebulization, very important. It involves supraglottis and glottis. Does it involve the glottis also and the supraglottis also? It involves, yes, it involves supraglottis and glottis both. Both. I'm waiting for your answers. Yes. Yes, no. So it involves what? Only supraglottis. Yes, it involves only supraglottis. So the voice of the child is going to be normal. Glottis is not involved here. That is why acute epiglottitis is also mentioned as acute supraglottitis. Okay, now let us see this choice. So this is again incorrect. If required, intubation should be preferred over tracheostomy. What do you think? If this child goes into respiratory distress, you are in the emergency, you are in the OPD, by chance the child goes into respiratory distress, what will you prefer? Yes, will you go for tracheostomy here or will you prefer intubation here? Intubation, tracheostomy, intubation. Come on, what do you think? All these things you are going to deal in the OPD, in the emergency. Yes. So, what will you prefer, intubation or tracheostomy? What is less invasive? Yes, tracheostomy or intubation. What should be done? Yes, intubation should be preferred. Yes, intubation should be preferred over tracheostomy. Tracheostomy is an invasive procedure where the chances of morbidity, mortality is high, and especially in children, it is more. So nowadays, tracheostomy is never the first choice in kids, in infants. And as we can see here, this is an acute condition, this is acute infection. You give antibiotics and the condition is going to resolve. So probably if at all you require intubation, you are going to not require it for more than maximum 2 days, 3 days. The steroids, the antibiotics work and the child dramatically improves. So if we have to go for it, we have to go for intubation. Intubation should always be preferred over tracheostomy. Yes, so please remember this. So whenever in any child you're dealing with stridor, think of intubation first. Yes, if it is a prolonged intubation that you require for more than 3 weeks, then you will think of going for tracheostomy. So here the answer is B and E. So yes. So what is the answer here? It is 4. It is 4. So these are the practical things that you need to face in the OPD or in the emergency. You know everything theoretical about acute epiglottitis, but whenever the patient comes, how are you going to deal with it? Yes, immediately you go for an X-ray, it confirms, start steroids, start antibiotics, start nebulization with adrenaline, and if at all the child goes into stridor, go for intubation, monitor the child. Once you have intubated, you can then go for fiber optic laryngoscopy to see how the epiglottis is recovering. Once you feel that the child is good enough, maybe in 2 days, 3 days, you can just extubate the child. So that is what you need to know here, and that is what you will have to practice. And these are the type of things that are asked in your exams, and then you feel that, my God, we knew everything about epiglottitis, and what are these simple stupid things that are being asked? Because this is exactly what you need to decide when you're sitting there in the OPD. So okay, so now let us come to the next question here. Listen to the sound of breathing of the child and tell me the site of origin that it can be from. So let us listen to this. So did you hear that? Yes, did you hear that? So the child of breathing was what you heard, and the origin of this can be. What was this? Was this an inspiratory stridor? Was it a biphasic stridor? Or was it an expiratory stridor? Yes? Or was that a barking seal? Are you sure? Yes? What is this? This was in both inspiration as well as expiration. Yes, very good. It was in both inspiration and expiration. Sindhu, Pragati, Ashish. Yes, Sarthak, Swati, all of you giving me the correct answer. Yes, it is. It was in both inspiration and expiration. So this is a biphasic stridor. In supraglottis, the stridor is inspiratory. In subglottis, it is biphasic. In subglottis, it is biphasic. Biphasic can also be seen in glottic conditions, though in glottic conditions, usually the stridor is inspiratory. Yes, in nasopharynx, if there is any obstruction of the nasopharynx, for example, there is hypertrophy of the adenoid. So you must have heard, if there is any nasal obstruction, if there is a large base of tongue that you see in obese people, whenever they lie down, the base of tongue falls down, and they have apnea, the sleep apnea. So what is the type of sound that is produced in respiration whenever there is obstruction of nasopharynx? Is it different from stridor, or is it the same as stridor? Is it also called stridor? Yes, let me see what you answer. Is that also called stridor? How to identify by listening? Sonali is asking me how to identify by listening. So you want to listen again? Yes? Yes, listen to this again. Listen to this again. Yes, it is both in inspiration and expiration. Yes, yes, very good, excellent. I can see all of you are asking. It is different, answering the correct answer. This is called as stutter. This is called as stutter. Stutter is something like the sound of a snoring. Stutter is like snoring. Yes, snorting, snoring sound. And this is different from stridor. How do you identify? You must have heard so many times a snore. So that is a very low pitch sound, whereas the stridor is a high pitch sound that is produced at the level of larynx and below. Above the level of larynx, the sound that is produced by obstruction is what is known as a stutter. Okay, so at the level of bronchi, what do you think? Will there be a biphasic stridor or will there be expiratory stridor? Biphasic? Biphasic? Yes, so after listening, Sonali, the moment you hear before this you heard a inspiratory, right? Inspiratory stridor that we saw in acute epiglottitis. This was a typical biphasic stridor in bronchi up till the secondary bronchi. Up till the secondary bronchi, it is a biphasic stridor. It is a expiratory stridor. Subglottis up till cervical trachea. Subglottis up to cervical trachea is biphasic. When you come down to the intrathoracic trachea, up to secondary bronchi is expiratory. What is wheeze? Wheeze is beyond secondary bronchi. Beyond secondary bronchi is wheeze. Yes. At secondary bronchi is expiratory. Yes. Below that is wheeze. So now let us come to the next question. The next question, again we have a video clip and state true or false regarding the condition. So let us see the video clip. Yes, so did you see the clip? Yes, so what is the diagnosis that you have in your mind now? What's the diagnosis in your mind? Yes, this was a child. You saw that when the child was lying supine, there was a shrill sound, a high pitch sound you could hear during. What was the stridor? Was it inspiratory? Yes, very good, Pragati. It was an inspiratory stridor. Yes, whereas when the same child was made to lie prone, the stridor was not there at all. So this is, yes, very suggestive of, yes, Laryngomalacia. So let us see the choices. This is the most common congenital cause of stridor. Is this the most common congenital cause of stridor? Yes, the most common congenital cause of stridor is Laryngomalacia. It involves the whole of larynx. What do you think? It involves the whole of larynx? This is laxity. This is excessive redundant tissue in yes. Yes, you want me to play again? Play again. Yes, quickly I'll play again. Yes. Yeah, the child is lying without any noise coming from the child. Yes, so does it involve the whole? No, it involves only the supraglottis. So this is incorrect. This is false. We have tried true or false. So again, this is the Ames pattern question. Surgical correction is usually required. Yes. Arijit says it is no. Is surgical correction required usually? Or yes, all of you. Surgical correction is it required? No, surgical correction is usually not required. It is required only if the child does not get relieved by 2 years of age. The stridor does not revert by 2 years of age. A folds are elongated. So this is again false. A folds are elongated. AE folds are elongated. D choice. Yes. D. Is D true or false? D. D. Yes, reassurance is the management. Conservative regresses by 2 years. AE folds, epiglottic folds are elongated. Is that true? D. Elongated. Elongated. Tell me. Yes, Sameer, Divya, MK. All of you say that it is not. Prachi says no. Arijit says no. Sarthak says no. Udyan says it is a short and floppy. So D is false. D is false. Yes, so these are the minor things that we need to remember. The inlet is floppy. The inlet is floppy. The epiglottis is curled up, omega shaped. Area epiglottic folds are very short. That makes them very floppy, and that makes the inlet very narrow. The child can have difficulty in feeding. So this is, yes, tell me the answer of this. Let me see whether you answer this correctly or not. E. Can the child have difficulty in feeding? Can the child have difficulty in feeding? E. Can the child have difficulty in feeding? E. I'm waiting for your answers. Difficulty in feeding. E. Is that true or is that false? So this area epiglottic fold, that is false. Area epiglottic fold are short. They are short. They are short and floppy. They are short and floppy. Yes. Feeding difficulty. Most of you say it is no. Can there be difficulty in feeding? How does the child feed? Whenever there is, this is a supraglottic condition. Okay. No difficulty in feeding. I can see most of you are answering that there is no difficulty in feeding. Okay, so listen to this carefully. Now, whenever this is a supraglottic condition, so whenever we make the child lie supine, the stridor increases. Yes. And can we feed the child, the infant? Can he be fed in sitting position? No, it has to be in supine position. And secondly, when does the stridor increase? Whenever the respiratory effort will increase, like whenever the child is playing, whenever the child is crying, whenever the child is active, whenever the child is feeding. In all these situations, the respiratory effort increases. So when the respiratory effort increases, the stridor will be bound to increase. That is why children of laryngomalacia, initially at a few months of age, they might not be troubled by the stridor, but the many a times the parents get the child when the child is maybe 6 months, has started crawling, has started playing a little. So maybe they get the child at 6 months, 1 year, when the stridor increases. So there can be difficulty in feeding, but yes, it is not too much. The difficulty in feeding is not too much. If the difficulty in feeding, if it is a very severe laryngomalacia, in those cases the difficulty in feeding can be more, and that can lead to failure of thriving. In those cases, we go for surgical reduction, we go for surgical correction, or we go for surgical correction when the stridor does not regress after 2 years of age, and or the feeding difficulty is so much that there is failure to thrive. So this is not very common. It occurs in severe laryngomalacia, and we know that this is the most common congenital anomaly of the larynx. And yes, this is usually does not cause very severe difficulty in feeding. So what will happen is that the child will feed slowly, so that the work of breathing does not increase. The child will take a long time to feed. So otherwise, usually it is not a problem. So the child can have difficulty in feeding. Yes, the child can have difficulty in feeding. So this is true. The cry of the child is hoarse and the cough is like bark of seal. The cry of the child, is it hoarse? Is it hoarse? Yes, Mathri says no. So yes, the hoarse cry is not seen. Bark of seal cough is not seen. This is a supraglottic condition. Bark of seal cough will be seen in, yes, in Croup. Yes, very good. It will be seen in, yes, excellent. It will be seen in Croup. Yes, the cry is normal because the two vocal cords are normal. So cry is normal. So here the answer is, here again this is false. So now let us come to the next question. A 2-year-old fully vaccinated child presents with sore throat, presents with fever for the past 3 days. So this is so common, no? child, 2 years old child has come with sore throat, has come with fever. Sore throat and fever is so common in children, and it has been added the child is fully vaccinated. Wonderful. Now for 3 days the child has sore throat and fever, and now the child also develops another thing, and that is hoarseness. The child has a cough which sounds like this. So there is hoarseness now, which means that the larynx is involved and the true vocal cords have started getting involved. There is also cough, and cough sounds like this. So let us listen to how the cough is sounding, and listen to this very carefully. This is the characteristic, and yes. I will like to play it again for you. Yes. So what is the answer? Tell me the most probable diagnosis. Yes. So what is the most probable diagnosis? Is it whooping cough? Is it foreign body aspiration? Is it croup? Or is it acute epiglottitis? Now, even when we had not heard the child coughing, even when we did not hear the cough of the child, could we find out what the diagnosis was? It is a fully vaccinated child. See the important point that is mentioned in the question. It is a fully vaccinated child. Yes. Yes, very good. Fully vaccinated child. Fully vaccinated, can it be whooping cough? Can it be pertussis? In a child, we always give the DPT vaccine. Yes, we also give the booster. So it cannot be whooping cough. Foreign body aspiration. What do you think? Can it be foreign body aspiration? The child has come with sore throat. The child has come with fever. Foreign body aspiration will not have the history of sore throat and fever. Foreign body aspiration will be acute stridor, acute obstruction of the airway. So acute epiglottitis. What do you think? Can it be acute epiglottitis? In acute epiglottitis, there is no hoarseness. It is supraglottic laryngitis. Vocal cords are not involved. So, and the main complaint of the child there has a very toxic look, and the child is drooling of saliva. The child has difficulty in, yes, a lot of there is, yes, a lot of difficulty in swallowing is there. So here none of that is mentioned. So otherwise also we know that the answer is laryngotracheobronchitis, but yes, I wanted you to hear that sound and know that that is how a barking seal sounds like. So that is your homework today. You are going to open the Google and see what is the barking seal, how the barking seal sounds like, and what is the cough of a whooping cough. Yes, the whooping cough was, yes, the vaccination is there for whooping cough, but the vaccination does not last for life. It is being seen that now again adults and elderly are prone to whooping cough again. What is the type of whooping cough? It is known as 100-day cough, and the typical type of whooping cough, the typical type of cough in whooping cough is paroxysms of cough. There is fits of cough in between. When the child has cough, the child is not able to breathe, so in between the bouts of cough, the child takes a long deep breath and then again has bouts of cough. Let us listen to how that sounds. Yes. So did you hear the child had bouts of cough, fits of cough, and in between the child took a long deep breath and again the child started coughing. Yes, I will play it for you again. Yes. So that is the typical paroxysms of cough that, yes, Shivam, excellent. That is the paroxysms of cough that you are going to see if it you have to diagnose that that is a patient of whooping cough. That is a patient uh, of pertussis. So that is the typical bark of seal. The, yes, the animal seal. Yes, look on Google what is a typical bark of a seal, and that exactly matches with the laryngotracheobronchitis. So that is known as barking seal, seal-like cough. So now let us come. Yes. So we have the next question here. Premature infant was intubated for 6 weeks. After extubation, the child developed a biphasic stridor. Repeated attempts to extubation were unsuccessful. Rigid endoscopy was done. What are the various treatment options for this patient? So without I show you the rigid endoscopic finding, you are going to tell me just by reading the question. Many a times the endoscopic finding will not be given to you, the picture will not be given to you, the question will be asked, and that is only this. So what by the question do you come to know the diagnosis? What diagnosis have you made by the question? Yes, just by reading the question, it is a premature infant. There is a history of intubation, and that too for 6 weeks. A very, very important history you have here. 6 weeks. We know intubation not recommended for more than 3 weeks. And after extubation, the child again has biphasic stridor. Yes, biphasic stridor. So what do you think the child has? Yes, Prithvi? Prithvi? What do you think it is? Yes, Prachi. Can it be, see, Prachi says, Prachi, can it be intubation granuloma? Yes, intubation granuloma can occur following intubation, but it will not be such a immediate presentation that the moment we remove the tube, the child will not have stridor immediately. Intubation granuloma can lead to hoarseness. Intubation granuloma will not lead to stridor. Is that clear? Intubation granuloma are small granulomas that are present in the vocal process area. Yes, small granulomas like this, they will not lead to stridor, for which you will have to intubate the child again, and they will not be such an acute presentation. Yes, very good. I can see all of you are telling me biphasic, so it is subglottic. Yes, yes, it is. Now let us see. Yes, so this is the typical presentation of this child, and yes, it shows the area, the subglottic stenosis. We can see all this is stenosed. All this is the stenosed segment. So now let us see what can be the treatment option. Now this child, we cannot keep the child intubated. We cannot keep the child, we cannot tracheostomize this child for life. So what do we do? Can we go for balloon dilatation? Yes, yes. If it is a immature tissue, if it is a soft, if it is a soft stenosis, then by balloon dilatation, it can get dilated. So yes, balloon dilatation is an option. Cricoid split and costal cartilage grafting. What is cricoid split? So here we have the cricoid, which is cartilaginous all around. What we do is we split it. We split it, and we can put a cartilage graft in between. Yes, we can do anterior cricoid split and cartilage grafting. If it is very narrow, we can also do a posterior cricoid split, and we can also do a posterior cartilage grafting. So can you see the lumen? We are increasing the lumen, yes, of the cricoid. Yes, so we can do depending upon the stage. Now, quickly, you are going to tell me that if, yes, very good. For harsh stenosis, we go for costal cartilage grafting. So this is again true. Now, can you tell me that if, okay, do we go for cidofovir antiviral? No, this is stenosis antiviral. Do we go for antiviral? No. Mitomycin C. Mitomycin C. Do we go for mitomycin C? Yes, we know that it is anti-neoplastic agent, but it has got anti-fibroblastic activity. So according to the, whenever we are giving an incision operating on the cricoid, the chances of fibrosis and restenosis are very high. So that is why whenever we operate on the cricoid for stenosis, we always apply mitomycin C to decrease the chances of fibrosis. Yes, can you tell me, all of you, that what is the staging, what is the grading system for subglottic stenosis? What is that known as? What is the grading system for subglottic stenosis? That is another question that is asked in your exam. The grading system of subglottic stenosis, what is that known as? Grading system is known as? Yes, I know you will tell me the answer. I know you have studied it very well. The grading system is known as, what is that known as? Yes, Swati, Arijit, Eva, Sarthak, Samir, Pragati, I'm waiting for your answers. Uh, yes, tell me. Yes, it is Meyer cotton. Meyer cotton. It is Meyer cotton. Meyer cotton. Now, yes, I have a question here from Shibashish. That if repeated attempts to extubation were unsuccessful, it means the stenosis must be fibrosed. Yes, it is possible that it is just a mucosal outgrowth granulation that has occurred which is causing the stenosis. In that case, it will be a soft stenosis. Or if it has got fibrosed, that is a hard stenosis. Also, it is possible that this child is subglottic stenosis common I mean, what is it? The most common congenital anomaly of the larynx is? Yes, that is how you remember that supraglottic is most common. Then glottic is second most common. And then subglottic. Subglottic is third most common. So most common congenital anomaly is supraglottic, that is laryngomalacia. Second is glottic, that is vocal cord palsy. And third is subglottic, that is the subglottic stenosis. So subglottic stenosis can be congenitally also present, that the cricoid is very narrow. So in that case, we do not know that the intubation has caused the stenosis. It is a hard stenosis or it is a soft stenosis. It is caused by intubation, which can be a soft stenosis, or it is already there, has been already there congenitally. So whatever it is, that we can come to know by rigid endoscopy. And so what is the answer? Yeah, bevacizumab. No, this is a monoclonal antibody. We do not use here. So the answer is A, B, and D. A, B, and D. So yes. Yes. So what I was asking you, what is the gold standard for diagnosis of laryngeal conditions? For laryngeal conditions, the gold standard for diagnosis is rigid endoscopy. Rigid endoscopy. The flexible endoscopy usually cannot go beyond the true vocal cord. That is the awake endoscopy that we do. That cannot go beyond the true vocal cord. But for most of the conditions of the larynx, the gold standard is rigid endoscopy. The flexible endoscopy can be the first. Yes, but if we want to examine the whole of the larynx, the subglottis, the trachea also, we have to go for a rigid endoscopy. So we have the next question here. A 3-year-old child presents to the OPD with mild difficulty in breathing. Okay, so there is difficulty in breathing for 3 days. There is history of hoarseness for 1 month. So, okay, by 3 days, we thought that maybe it is acute presentation. So there is difficulty in breathing for 3 days, but there has been some complaint of the larynx for past 1 month, and there is a history of hoarseness for 1 month. No fever. Okay, no fever. What does that tell you? There is no fever. No fever means, yes, there is no fever, which means it is not an infective condition. There is no difficulty in feeding. So we already know it is the glottis is involved because there is hoarseness. So there is no feeding. Supraglottis is not involved. Child was normal term vaginal delivery. No history of allergy. No history of asthma. No history of previous surgery. Fiber optic laryngoscopic finding is given. True about the management. Now before I show you the fiber optic laryngoscopic finding, think and tell me what this can be. We know that this is no fever, so non-infective condition of the larynx, which is involving the true vocal cord. Is that true? Yes? Yes, it is not infectious condition of the larynx at the level of the glottis, at the level of the true vocal cord. So there has been hoarseness, so some condition of the true vocal cord. So initially there was hoarseness and now there is some difficulty in breathing also. So that condition is progressive. Yes, so it is a progressive condition. So what comes to your mind? What can this be? Yes. Now, if there is a vocal cord palsy again, there can be hoarseness, there can be difficulty in breathing. Yes, but usually both of them occur together. Now, if there is a web, at the level of the glottis, because we are thinking of the conditions at the level of the glottis. So if there is a web at the level of the glottis, then this child is a 3-year-old child and he did not have any complaint initially. So which means that it cannot be a web. If there is a web, the child congenital, when the child is born, the child initially itself has a has a weak cry. Now let us see this. The endoscopic finding.
Big breath. Say E, E, E. And now say he.
Yes, so can you see all these? Yes, can you see all these? Yes, at the level of true vocal cord. So this is the arytenoid, the false vocal cord. Here was the epiglottis. So here we are seeing the true vocal cord where we are seeing, yes, multiple papillomas. Yes, so this is juvenile laryngeal papilloma. Excellent. Okay, now let us see. Tracheostomy should be done. Tell me the answer. Tell me, should you go for tracheostomy? Ritam, Divya, Arijit. Should we go for tracheostomy? Swati, Eva, Archita, Prithvi. Yes, I'm waiting for your answers. Divya, Ritam, Shivam, Sameer, Rushab, Sarthak, Swati, Anshu, Eva, Prachi, where are you? Yes, Sarthak. Tracheostomy should be done. Tracheostomy. Tracheostomy, no, tracheostomy should not be done, because when you are doing tracheostomy, you are creating additional route through which the papillomas can grow and there can be exuberant spread of the papillomas. So we are not doing any tracheostomy anywhere. Yes, tracheostomy is not done. Antiviral should be given. Antiviral, yes. MK antiviral, should we give antiviral? Come across. Yes, yes, tell me. Antiviral, do you give antiviral? Yes. Should we give antiviral? Yes. Which antiviral? Which antiviral will we give here? Which antiviral do we give here? And yes, that was a question in your exam recently. Which antiviral do you give here? Yes. Which antiviral? Do we give acyclovir here? Do we give balasovir here? Which antiviral do we give here? Yes, Mrinmoy. Do we give antiviral? This is juvenile laryngeal papillomitis caused by HPV. HPV strains 6 and 11, out of which 11 is the more virulent strain here. Yes, we give Cidofovir. Very good. I can see you answering. Yes, we give Cidofovir. Yes, Venkat. Yes, Divya, we give Cidofovir. So this is correct. The excision should be done by microdebrider. Should you excise? Now, when there are uh, so many papillomas that you are seeing on the true vocal cord, do you think that we should go for a microdebrider excision or should we go for a laser excision? What should be preferred, laser or microdebrider? What will you prefer? Yes, we know that laser produces a lot of heat. Should we go for laser here? Laser, we know that is it a recurrent condition? Yes, yes, remember this, listen to this, that this is a recurrent condition. Here, what you are seeing here, what you're seeing here on the true vocal cord, we are going to remove it. But will it recur? Yes, the chances of recurrence is very, very high. The chances of recurrence is very high. So these kids, they present with recurrences very, very frequently. It can be 2 weeks, it can be 1 month, it can be 3 months, it can be 6 months. So which means that they require repeated excision. Now, do you understand this? That why are we doing excision? Excision is not to cure this. This is a viral condition. So this is not going to be cured by the excision. But when we are excising it, we are excising it to clear the airway so that the stridor, the child right now has difficulty in breathing, the child will develop into stridor. Yes. So yes. So the stridor, to relieve the stridor, we are going to excise this, and this child is going to come to us again and again. So whenever we are using laser, then the laser emits heat. There is scarring following which, and this is at the level of the true vocal cord. So true vocal cord, this is at the level of the true vocal cord, which means that during following laser, the scarring will lead to permanent changes of voice, permanent scarring of the larynx. There can be additions of the vocal cord. So that is why laser is not the first choice nowadays. Is that clear? Laser is not the first choice nowadays. The first choice, the microdebrider, is the gold standard. The gold standard for the management of juvenile laryngeal papilloma. Juvenile laryngeal papilloma, the gold standard is excision by microdebrider. Now, yes, now let me ask you this. This is what I want to ask you. The disease could have been prevented by vaccination of the mother. All of you, tell me D. Yes, tell me D. D. See, whenever we are doing laser, laser is a hot method or cold method. Laser is a hot method. It causes the destruction, charring, as well as the bleeding is less. Yes, I can see one of you are saying that the bleeding can occur due to laser. Laser is good when we do not want the bleeding to occur, because when we do cold excision, what is the meaning of cold excision? Cold excision means you are removing it with knife, or you are removing it with microdebrider where there is no heat produced, then the chances of bleeding is there, but here at least scarring is not there. So that is why we go for microdebrider, and here the bleeding is not that much, so which cannot be controlled. So we go for microdebrider. So do you think that the disease could have been prevented by vaccination of the mother? Yes, vaccination. Okay, so yes, I get the answer. Sujata says, Maitri says that yes, vaccination of the mother. So now, can you tell me what is the vaccine? What is the vaccine? Have all of you got vaccinated for it? What is the vaccine? And this vaccination is done as early as 9 years, 9 to 14 years. Boys, girls, all are vaccinated for this. All the pregnant females get vaccinated for it. What is the vaccine to prevent human papilloma virus? Tell me the name of the vaccine. Which vaccines? Yes, you must have you must know this. Every option has a C. C can be done. Yes, very good. I can hear Shivam. Shivam, I can see Gardasil. Very good. Cervarix, Shibashish. Very good. Excellent. So we have these two vaccines, the Cervarix and Gardasil. And you should revise this to all the kids of your house, the pregnant females anyway, given by the gynecologist. So what do you prefer, Cervarix or Gardasil? What do you prefer, Cervarix or Gardasil? What has a better, Cervarix or Gardasil? What do you prefer? Yes, Gardasil. Nowadays, the recent Gardasil is known as the Gardasil 9. What do you prefer? Yes, very good. Swati says Gardasil 9. Yes, Gardasil 9. Gardasil 9, it contains all the for 6, 11, 16, 18, 31, 33, 45, 52 and 58. 52 and 58. 1, 2, 3, 4, 5, 6, 7, 8, 9. Yes, so it contains all these, the Gardasil. So yes, this has to be, if the mother was vaccinated for this, the child wouldn't have developed, and the vaginal delivery, that is why, is important here. Yes, Gardasil. Yes, very good. Excellent. Prithvi has given me all the 9. Excellent. I can see all of you so intelligent. Good, good. Wonderful. I'm so proud of all of you. Yes. Identify the given condition. Okay, now let us see this condition. Let us see this. Yes, so what was this? What was this? What is this? Is this the normal larynx in an infant? Is this how a normal larynx in an infant looks like? Is this laryngomalacia? Is this epiglottitis or is it tracheomalacia? What is this? What is this? What is this? Yes, that was such a lovely endoscopic picture. Is that normal? Is that laryngeal web? Yes, see that carefully. What is that? Yes, you can see the, what is that? Yes, just notice, just see that. Just see that whenever the child is inspiring, whenever the child is inspiring, the whole of the larynx is closing. See the epiglottis. Look at the epiglottis. Yes, look at the epiglottis. Can you see it is completely omega shaped, so enlarged. Most of this inlet, the epiglottis only. The A folds are so short. The arytenoids are here. And the moment the child inspires, we can see that the complete inlet is closing. We can see that the complete inlet is closing. Yes, so whenever this child will inspire, whenever this child will breathe in, all the tissues are going inside and they are going to block the inlet and they are going to lead to stridor. Yes, inspiratory stridor. Yes, so this is exactly how the laryngomalacia looks like. The tracheomalacia, what is tracheomalacia? Tracheomalacia is when the trachea is very floppy, it is soft and floppy. When the cartilage of the trachea is less, the tissue, the muscle is more, that makes the trachea very floppy. That can occur following tracheostomy. That can be congenital also. So yes, the answer here is, this is laryngomalacia. Okay, so yes, mention true or false about the given condition. So what is this condition? Yes, this is, I'm waiting for your answer. What is this condition that we are seeing? Yes, this is the, yes, tell me the diagnosis, the spot diagnosis by having a look at larynx. What is this? Just a look at the endoscopic picture of the larynx tells you the diagnosis. This is, yes, I'm waiting for your answers. Pragati, Prithvi, Swati, Sindhu, Divya, Eva, Archita, Meet. Yes, this is how a laryngeal web looks like. Very good. Rhythm, Sarthak, this is how a laryngeal web looks like. Okay, so you, now let us see A. Is this a vocal nodule? No, this is not a nodule. Nodule appears very thin like this. Yes, this can be seen in children. It is bilateral like this. Here we can see that this here is the true vocal cords, and completely this web is, there is a web in between the two true vocal cords. So this is how a web looks like. This is how a web looks like. Yes, so does it occur because of voice abuse? No, it does not occur because of voice abuse. This is a congenital condition, so this is incorrect. Presentation is weak cry, yes, since birth, because the level is the true vocal cord glottis, so there will be weak cry with or without inspiratory stridor. Yes, there can be stridor with or without. It usually resolves as the larynx grows. No, the management is, what is the management? Yes, it always has to be excised. If it is causing problems in speaking as well as in breathing, it has to be excised. And yes, this is one thing that is asked in your exams. Keys should be placed to prevent recurrence. Yes, tell me D, whether D is true or false. Tell me D, this is false, this is true, and resolves as larynx grows, this is false again. Tell me D, keel should be placed to prevent recurrence. Keel, yes, we can cut it by cold knife, that is by knife, that or we can excise it by laser, cielistic button or keel. Keel, cielistic keel. Yes, what is cielistic keel? Yes, by laryngo fissure, we open the larynx. Okay, now let us see here. So can you see here that this child has a web? Now, what we have done is we have excised the web here. We have excised the web. Yes, this excision can be done endoscopically by a cold knife, or it can be done with the help of yes, by cold knife or by laser. And then we place a keel. Now what is this keel? This keel is, now when the child will cry, when the child will speak, again both these vocal cords, during speaking the vocal cords are in adduction. So again what will happen is additions will form again. Additions will form. So prevent that, we place this in between the two vocal cords. So how do we place this? Just see how the keel looks like. So this part is placed on the thyroid. So we open the thyroid from between. That is what is known as, when we open the thyroid from between, that is what is known as laryngo fissure. Laryngo fissure. Laryngo fissure. Yes, we can do it either endoscopically or by laryngo fissure. So this part comes here, and in between the two vocal cord comes this part. So this comes in between the two vocal cord. This is how a keel looks like. So this is removed after around 2 to 4 weeks, or yes, around 10 days to 4 weeks. After that we remove. So during this time the complete healing has occurred, and the chances of recurrence is not there. So yes, keel should be placed to prevent recurrence. Yes, that is true here. The keel is placed to prevent recurrence. So that is true here. So I hope you understood what a keel looks like and what a keel is, and I'm sure you're never going to forget it now, that it is used for the management of laryngeal web. Okay, so that was what was for today, and the topics for the next Thursday, that is the 21st of May, is all the conditions of the larynx in adults except carcinoma. So all the speech disorders, infections, acute, chronic, all the conditions of the larynx in adults except for speech disorders is what we are going to do next Thursday. I hope today's session was of benefit to you. You have heard how the cough of so commonly heard, you must have heard this word so commonly, the barking cough, how it sounds like, how the laryngomalacia looks like, how the child of epiglottitis looks like. And do recommend do read and do all the questions from the book ENT for entrance exams. There's a one-stop book for pre-final, for interns, for post-interns, for everybody preparing for the entrance as well as for pre-final also. And yes, this is one slide that I really love. There are so many words here that are written, and all of these, can you see that persistence, consistency, determination, commitment, patience, all of these, can you see that all of these mean the same? When I look at the slide, I see that there's such beautiful words, and patience, consistency, determination, persistence, all these, are you seeing all these mean the same? Yes, because this is the thing that we lack so many times. We want to achieve something, we have the whole heart to do it, we have the love for it, but somehow we lose in between. We feel that no, we are losing our confidence, and this is too much for us. This is simply we cannot continue. So that is something that is very, very important. That is most important. You have to be persistent, you have to be consistent, you have to be determined, and all that requires a lot of patience. So even we at this stage many a times feel like just giving up so many times. So but just remember, be determined, be consistent, be persistent, and you can achieve anything in life, anything in life. So I know you already have all these qualities in life. All of you are really booming with all these qualities. So just keep going, and just remember and know that you're not alone. There are so many of you who are together in this endeavor of becoming very great doctors. So all the best and love you all. See you on 21st.